Endometriosis is an inflammatory condition. It is a condition of inflammation, right? And so think about what are the drivers of inflammation. Something easy someone could do is they could switch to an anti-inflammatory diet, right? Which means gluten, soy, dairy. We're going to pull those out.
So it doesn't always have to be medication.
Not all the time.
Yeah.
I've seen patients that have had stage 4 endometriosis, right? So they've had surgeries, they've been on a lot of meds, they have this poor quality of life. A lot of them will try to go anti-inflammatory diet. Now, it's not a cure,
right,
but it is helpful.
It helps manages the symptoms.
Absolutely, because it's underlying, it's an inflammatory condition. And so anything we can do to help decrease inflammation in the body should make us feel better. Yeah. Now, like I said, it's not curative, right? But it can help. Right. Now, is it going to help every single person? Or if we said across the road, everyone with endometriosis is now going to go anti-inflammatory diet? Unfortunately, no.
Hi, everybody. My name is Anastasia, and welcome to my channel. If you've been here before, thank you so much for coming back. And if you're new, come on in. Here we talk about everything. So today I am so excited. I have my old preceptor. She's a women's health nurse practitioner. And I practically begged her, dragged her to come and talk to us and give us some education, some information that we can all learn and find useful. So come on and let's have a chat. Hi, Gina.
Hi.
How are you?
Thank you so much for having me. This is
absolutely.
This is
Thanks
wonderful.
for coming.
Absolutely. I would do anything for you.
Oh, thank you. Me too. All right. So I know you. They don't. Tell us a little bit about yourselves and what made you wanted to go into women's health.
You know, how many times I've been asked this before in my career, and I am totally going to give you the most cliche answer, right? What got me into this? Because I knew from when I was very young. My mom still has little pieces of paper that I wrote on in like nursery school, you know, when they ask you, what do you want to be when you grow up? And I wrote on there nurse. And it asked me, you know, who was your hero? And I had written on this piece of paper that my aunt was my hero, and she was the only nurse in the family. And so, yeah, really from when I was very young, it's just, you know, people say like it's a calling, like whatever they do, they feel like they've been called to it. And I really have just always felt that way. And so it just made sense to keep going.
I do think nursing is a calling because the job of taking care of people, especially because some people actually don't even, you're here to help them. And they're mad at you, especially in the hospitals and in the nursing homes. So it's definitely a call, and I agree with that. Okay, so now you work with women.
Yeah.
How is that?
I love it.
Nice.
I love it. I couldn't see being in any other discipline. I mean, I tried. I did a very brief work in urology one time, very, very long time ago. I thought maybe I just needed to, you know, broaden my horizons a little bit. And I was like, no, absolutely not. I'm done. Yeah. Absolutely not. I crawled back to women's health. This is just, it's always been my comfort. It was the first job, you know, because I started out as an LPN. I started at the very, very bottom and just went all the way up. And my first job as an LPN was in an OBGYN practice. And
so you were just meant to be there.
I fell in love with it. Yeah, I just loved it. Yeah.
Nice. So now you are in a hospital setting.
So I was in a hospital setting for 13 years. I worked for a major university. And it was a great experience. It's where I went. I went to community college, got my RN, and then working at the university gave me the financial opportunity to advance. So I went back and got a bachelor's.
Nice.
Then I went back and got my master's, and then I went back again, got a second master's as a nurse practitioner. And so now I'm remain in women's health, but I'm going to be venturing.
Nice. Yeah. Okay. So tell us some of like, you know, typical women's health issues, something that most women deal with, but we're kind of ashamed to bring it out or talk about.
Yeah, well, so there are so many, but I think the one that I see the most in clinical practice is discharge, vaginal discharge. It's really what you see the most of. And a lot of times it's quite normal. There's nothing wrong with them, right? But they don't understand that that is a normal part of female physiology. It's supposed to be there. We want that there, right? And I think sometimes in society, you know, over decades, we have been made to think that it's wrong or shameful. And I know sometimes in cultures that's very important. And sometimes they don't understand. And so, you know, we're raised to think that something's wrong with it. It's unhealthy. It's you know, inappropriate. It's ugly. Right? Yes. And so I think that tends to sometimes make patients feel self-conscious. And so they come in for it and will sometimes, you know, demand, you know, testing. Give me some sort of swab. I know that this is not right. And so we do a lot of education, and that's really a good opportunity to educate, reassure them, kind of build up their self-esteem, and tell them that I have the same thing. So
Yeah.
I'm normal and you're normal,
Yeah.
you know,
Yeah.
unless there's other defining characteristics. Right? It's not always normal if it's, you know, if it comes with other symptoms, you know, pain, burning, odor, all those other things, then we have to look into it. But a lot of times it's very normal.
Yeah.
So many women that come in of all ages, you know, I can have a
Yes.
16, 17-year-old come in and I can have a 67-year-old, you know, everywhere in between, right?
Yeah.
It doesn't matter how old you are. The parts remain the same.
Exactly.
The issues that we have, they remain the same,
Yeah.
you know, and I think that's really why I do what I do, because it's not enough to just say, yeah, normal, and then just get them out of the office. You need to sit down, you need to make connections with them, you need to listen, right? Because patients want to feel heard.
Yes.
And that's something that we hear about when patients come in. And I hear it all the time. I feel like you're the first person that's ever heard me, the first person that's listening, you're the first provider that's actually listening to what I'm saying. And my first thought is, I'm so sorry.
Yeah.
How did you get to be this age and have all these providers where you never felt that you were heard?
That's
you know?
true. Yeah.
And so I'm very happy to,
especially in primary care. Primary care is like you have 15 minutes to see the patient and do your notes. Like, how is that even going to be, you know?
can't.
So you're just trying to like get everybody in and out, and it's just unfair, but that's just the medical system here.
That's our health insurance system right now.
Yeah, because the more people you see, the more you get paid.
Yeah.
Unfortunately.
Yeah.
All right. So now let's talk about importance of screening. Women's health screening that we should get done.
Yeah, absolutely. So that's a great question. So let's talk about Pap first. So Pap smears, the guidelines changed a very long time ago. So now we don't screen every year, which is great. Should make a lot of people happy to hear that they don't have to get their Pap smear every year. But we don't even start screening till the age of 21.
Okay.
And then after that, once you get above 30, then we can go to every 3 to 5 years, depending on background, depending on whether or not you've had the HPV testing, things like that. So that's the good news, because before, young patients wouldn't want to come in, you know, at 16, 17, 18, because they knew, you know, decades ago, we were papping everyone that came in, right?
Okay,
and that
so public service announcement, you don't have to get a Pap smear until you're 21.
Yes, and the reason we do that is, there's a couple of reasons. The first one is because cervical cancer, because that's what a Pap smear test is. We're screening for cervical cancer. And by that, we're getting a sampling of the cells that line the cervix, and we look at them under microscope. We make sure that they're non-cancerous. So that's what a Pap screening is. And we know that the likelihood of a patient under 21, even at 21, very slim that they're going to have cervical cancer. So we don't need to screen in that under 21. And the other thing is, a lot of patients, if we're going to screen them, we're going to find a lot of, in that age bracket, are going to have the HPV virus.
I see.
And so then there's many different strains of the HPV virus. Many of them, the body can put back away, tuck it up in the attic of their immune system, and we don't see it again for years. In other words, they can clear it out of their system.
On their own.
Right. And so by papping at these young ages, before the age of 21, we're going to find those type of results, and they lead to unnecessary worry and unnecessary biopsies and things like that, because we know that the body will clear out those viruses.
Eventually.
Yeah. And so we continue to screen for PAPs up to the age of 65, unless there was something that happened. You know, there was a history of abnormal PAPs, or maybe there was some type of cervical cancer, a CIN12, you know, those sorts of things, which we would then look closely
further
at the patient's history and then make recommendations based on what their history was. But for the average woman who's had PAPs her whole life, she reaches the age of 65, she's never had an abnormal PAP. It's the good thing about turning 65.
We should all wait.
You're done.
Yeah.
Okay. Now, of course, we do have some patients that want to continue screening. It just makes them feel good.
Better, yeah.
And that's fine with me. It's the patient's decision, right?
Yeah.
I make sure they're well educated. They know the guidelines. They understand that the option is that they can discontinue if they want to.
Yeah.
But many of them say, I just feel better. I'm going to continue to get it. And I'm okay with that.
Because now a lot of, you know, you see somebody that's 65 and they don't look like they have a long life ahead of them. So
absolutely.
Yeah, if you want to find out, sure, why not? What about mammograms?
Mammograms. So we start screening annually at the age of 40. Now, now, with that being said, if something happens and there is a history in someone's family, like let's say first degree relative, which is a mom or a sibling, right? And a lot of people don't realize that. They think that it's their grandma, their aunt, their great aunt. And it is surprising. I was surprised, and I learned, you know, decades ago too. Yeah. That's not a first-line relative. It's the mom and a sibling. Right.
Okay.
So let's say, for example, a patient comes to me and she says, you know, my mom was diagnosed with breast cancer. She was very young. I say, how old? She says, oh, you know, she was 50. I say, okay, how old are you? Right. Generally, we want to start screening 10 years before the onset of the cancer in that first degree
Okay.
relative.
So let's say a patient's mom was diagnosed at 50, then the patient presently will start being tested at 40.
We would, but we may even bring her in sooner. Let's say she says, well, my mom had, genetic testing and, she tested positive. So I went and I'm, BRCA1, BRCA2. Then we would do things a little bit differently. We would screen even earlier.
Sooner,
yeah.
Okay.
Or maybe that patient had genetic testing with counselors, or she may have had some pre-screening with a breast oncologist. Whatever the recommendations would be from oncology would certainly trump what we would want to do. We would certainly follow, recommendations and guidelines for that. But on the average, a low risk person, average
40.
age 40, we do it annually.
Okay.
Yeah.
So 21, if everything is okay for pap smear, and 40, if everything is okay for a mammogram. It's not a scary process.
It's not
right?
really.
So you just have to go to make an appointment with your OB. I think for the mammogram, even primary can write a script for mammogram.
Absolutely.
Yeah. So you don't even, for the mammogram, you don't need to go to an OB, but for the pap, you definitely want to go to your OB to get your pap smear done, starting at 21, and then it's every 3 to 5 years, depending on your history, your background, and whatever the results of the previous one was.
Yes.
Correct. Any advice or health tips for people that are dealing with chronic illnesses like PCOS, fertility issues, endometriosis, anything like that?
Yeah, absolutely. So the best recommendation I can give is to address these issues before you start to worry about fertility being an issue, right? So for example, if you have PCOS, make sure you see a provider who truly understands what PCOS is, that they screen for it properly, right? That you actually do have PCOS. Make sure that whatever the particular issues are with you, if you have PCOS, that they're getting addressed and you're being treated and managed, right? Same thing with endometriosis. Endometriosis is an inflammatory condition. It is a condition of inflammation, right? And so think about what are the drivers of inflammation. Something easy someone could do is they could switch to an anti-inflammatory diet, right? Which means gluten, soy, dairy. We're going to pull those out.
So it doesn't always have to be medication.
Not all the time.
Yeah.
I've seen patients that have had stage 4 endometriosis, right? So they've had surgeries, they've been on a lot of meds, they have this poor quality of life. A lot of them will try to go anti-inflammatory diet. Now, it's not a cure,
right?
But it is helpful.
It helps manages the symptoms.
Absolutely, because it's underlying, it's an inflammatory condition. And so anything we can do to help decrease inflammation in the body should make us feel better. Yeah. Now, like I said, it's not curative, right? But it can help. Right. Now, is it going to help every single person? Or if we set it across the road, everyone with endometriosis is now going to go anti-inflammatory diet? Unfortunately, no. But I have seen a lot of clinical benefits in patients. So I would definitely recommend getting those conditions under control. Right. So if you have endometriosis, you really should see a specialist who understands it, who treats it, who manages it. Sometimes that's a doctor called a MIGS, a minimally invasive gynecologic surgeon. A lot of those are endometriosis experts. Because a lot of times with endometriosis, you have those endometrial attachments that need to get removed. Not all the time, but sometimes as a last resort, patients are so debilitated, their quality of life is so poor. They've tried other alternative treatments that aren't helping. Sometimes then they move to surgery and they have those endometrial implants, cleared out, so to speak. So you would want to see a MIGS physician and have that addressed. Make sure that your endometriosis is as under control as possible before you want to attempt pregnancy, right? Things like obesity, right?
Yeah. It's a big issue.
I mean, you're in family medicine, so you understand, right? So it's a big driver of a lot of issues, especially fertility. The higher your BMI, the more issues we see with the fertility process. So something easy you can do, at least try to drop 10% of your body weight. Even with 10% alone, we see an improvement. We see a return to better fertility.
Oh, interesting.
A lot of times it's that loss of 10% of body weight that gives them
like a
little boost to their self-esteem. Now they're feeling better. They're like, wow, I did that. I can do more. And
so it could be psychological too.
Absolutely. Yeah.
Interesting.
Absolutely.
Yeah.
So get all of those things, whatever your chronic conditions are, whatever you're bringing to the table before you become pregnant, try and have those things, addressed, right? This is very important. Find someone maybe that does preconception counseling visits where they're going to look for all of these things. Make sure you're not coming in with high blood pressure, right? Or high cholesterol. Or maybe we're going to discuss the obesity. We're going to look at your environmental risk exposures, and we're going to talk about that,
levels.
Right? Your sugar levels, right? Because all of those things can cause issues with pregnancy. Not only fertility, right? Because they can also affect fertility, which is, the ability to even become pregnant. Then if you become pregnant and you have all of these high risk issues and now you become pregnant, now you have a high risk pregnancy.
Exactly.
Which increases the risk for, things to happen to mom, for things to happen to the baby or the pregnancy itself. So it's really about risk mitigation. And the best way that you can mitigate those risks is to take care of those issues before.
Okay.
Yeah.
So let's say somebody has gone through this, they're pregnant now. Any pregnancy tips? While you're pregnant, anything to help, especially like with nausea, things, things like that. Yeah.
Yeah. So nausea is, it's a good and it's a bad thing, right? It's good because we know that those pregnancy hormones are climbing and they're doing what they need to do. It's bad because
you feel like crap.
Sorry to say it. Your first 12 weeks could be rough, but not everyone goes through it. Right?
That's true.
Or sometimes it's really mild. They have a little bit of it in the morning for a few weeks and then they get over it.
That's it. Yeah.
But, diet, avoiding the fried, the greasy things, you're going to stick to a plain, bland diet. And the things I tell my patients early on is, don't worry about hitting the entire food pyramid right now. Like you're 6 weeks pregnant. You don't need all of that right now. Like you're okay unless they're really coming in underweight, something like that. Eat the best you can, whatever you can tolerate, try and make it the best thing that you can tolerate. Now's not the time to start eating candy and soda and all those things. Try to make good choices, but things that you can tolerate. Things like vitamin B6, which is over the counter, very safe in pregnancy, very good for nausea in pregnancy. Ginger is also very good, very safe to have in pregnancy. They make like ginger lozenges that you can try, or the ginger lollipops,
the
candies. Yeah. So you got to watch everything in moderation, but first trimester,
it's rough,
but take it easy.
Because a lot of people, what happens is, especially with first pregnancies, it's like, I'm pregnant, so I'm going to try to be as healthy as possible. So they start eating salads or, whatever. And
it's upsetting.
Yeah. You just eat whatever you can tolerate, at least in the beginning.
Yeah.
Because it's not like you're going to lose weight unless you're, severely hyperemesis or something. You're not going to lose drastic weight if you're just eating bland food.
Yeah. Yeah, exactly. Absolutely. And you want to make sure that you're taking your prenatals, you're getting your supplements, sleep hygiene, very important, right? You want to make sure that you're getting rest, especially that first trimester is brutal.
Yeah.
Because there's a whole system, being set up in there. Yeah. You are tired.
All the time.
Yeah. So make sure you're getting your rest when you can. And hydration. Hydration can be very difficult in the first trimester because you're feeling so nauseous. So instead of 3 big meals, we always recommend very small meals frequently throughout the day. So instead of eating this big breakfast, this big lunch, this big dinner, you're going to break that down. Maybe have a half or a quarter of what you typically eat for breakfast. Wrap it up, put it away. A couple hours later, come back, have a little bit more, put it away. Lunchtime, same thing.
Yeah.
Small things. You don't have to eat a big salad and a big sandwich and fruit. Cut it down a little bit, and just like graze almost, and graze throughout the day. We find that it is better tolerated on the stomach. The other thing is too, don't do your fluids with your meal. It makes it a lot easier for gravity to bring things back up if we're drinking lots of water with our meals. So have your meal, wait about an hour or so, then have some fluids. Then wait, then have some more of a meal. So little tricks that you can
and then even try. With the fluids, it doesn't have to be water if you cannot tolerate
Absolutely,
it.
That's right.
Because I remember I couldn't drink water. So I couldn't even drink soda. The only thing I could drink was tea. It had to be black tea. I don't know why. But with no sugar. If there's sugar in it, it was a problem. Yeah. And that's all I could drink was black tea.
Well, that's okay. Tea is very good for you. And sugar we could do without.
Exactly.
So you did a really good thing.
Yeah.
Make a green tea, and that's even better.
Exactly.
And try and keep it decaf. You can drink all the tea that you want as long as it's decaf. Yeah. Try to cut it down with a little bit more water too during pregnancy. But tea, for the most part, as long as it's a clear beverage, is okay. And I tell my patients that whatever you can tolerate, if it's, you're getting apple juice down in the morning, but you can't get water down, whatever, have some apple juice. Yeah. You want to get hydrated. So you do what you need to do. Yeah. And then little by little, you start to add the water back in, or sparkling, drinks like those LaCroix and things like that. A lot of patients
like
tell
fizzy
me,
drinks.
Yeah. They're like, I can't drink plain water, but I can do like a LaCroix or something like that.
I didn't have that when I was pregnant.
Yeah.
Well, I didn't know about it then. Yeah.
Sometimes just the effervescence in the drink just makes them feel a little bit better. So it's just about finding what works for you,
Yeah.
But you definitely want to be on supplements prior to pregnancy. That's big too. lot of, patients will say, well, I was ready to start trying for baby, so I just started on my supplements. You actually want to be on those prenatals and those supplements about 6 months before conception. Yeah.
Okay.
Yeah, you want to get that folate in, especially because that helps decrease the events of, neurological defects. Yeah, for sure.
So if you're planning on getting pregnant 6 months, you have to, that's like thinking way down the line. You have to think 6 months ahead. And
not
start
everybody's
taking,
is thinking that, but it's important.
Yeah.
That's an important piece. So I tell patients, if you think you're going to want to get pregnant in the next year or so, start a prenatal now. It's not harmful.
It's not going to harm. Yeah.
Start taking it now.
Yeah.
And then
so at least 6 months. So you could do it before 6 months.
You
but
could
at least 6 months or
6
up
months
will be
minimum.
better.
Yeah. Then I'll have some patients say, well, oh my gosh, I just got pregnant. We weren't planning on it. It happened. Now what am I going to do? I'm not on a prenatal. Did I hurt my baby? They get very, I say, absolutely not. Babies will thrive. It's even better if we can get you before pregnancy, but we just get them started on prenatals and we go from there.
Prenatals, very important.
Yeah.
Before pregnancy and of course during pregnancy. And then they have the post pregnancy vitamins,
which are also very good too, especially too
like breast milk.
If you're going to be breastfeeding, then you want to certainly continue those or switch and do those postnatal ones.
Cool. All right, now let's talk about advocating for ourselves as women. Like we talked about earlier, you go in to see a doctor and because of time and everything else, you're kind of rushed out. So as women, knowing ourselves, what are some tips as a provider that, if a patient comes to you and say to you, kind of makes you slow down and give them a little bit more attention than, maybe you normally would?
Well, the first thing that's going to make me think twice is when they say, you're my fifth provider. You're my fifth OBGYN. That's a red flag right there. Why have you had so many? What happened? And so I will engage in some conversation about that. Tell me about that experience. What led you to me today? What are you looking for that you haven't had with your prior providers? And a lot of them will give me insight then, well, I didn't feel heard, which we talked about earlier. And that's a big thing, especially too, because GYN care is so personal. It's not like going to the ear doctor and say, hey, my ear hurts today. I want you to do we are getting patients at their most vulnerable moments. They're undressed. They're in a see-through paper gown.
I know. And I work in healthcare, and I know the benefit of going to get all those tests done, and I still hate it. I will wait till the very last minute to schedule an appointment to go get my pap smear done because it's just not pleasant.
I know. And so I try to be very mindful of that. So the first thing I do is I don't talk to someone when they're undressed. I don't get them in that state because that takes their power away from them.
Oh, that's good.
And I like to explain to my patients, you don't work for me. I'm working for you right now. You've come to me. You've basically hired me for a service and I'm working for you. So you control the room right now. It's not the other way around. And I think that is an idea that not many people are thinking about, but they should. And I tell my patients that not only here in the GYN office, but when you go to your primary care doctor, when you go to your gastroenterologist, they all should be in that same mindset. What is it that you're expecting from this visit today? How can I better serve you? How can I better serve this relationship, right? Because if you don't get your patient to connect with you, they're not going to be compliant with your treatment. Right. And if they're not compliant, they're not getting better.
They're not going to do it.
Yeah. And that's ultimately what I want to make them feel better. Right. They're obviously coming to me with some sort of issue. Even if it's an annual well visit, we're going to uncover something. Right. And so I want to fix that for you. But I can't do that if we are not doing shared decision making. Right. If you don't trust me. And that's the first thing that you do to establish trust is I'm going to talk to you with your clothes on. Right.
Now when you're
like this, you're sitting in a chair, we're face to face. And the other thing I do too is I put my laptop away. My charting is really not my priority, and that you don't see a lot of today. And I will have patients tell me that.
No, you don't. We're literally okay, the computer's here and you're talking and it's, because it's terrible because the problem is nobody wants to stay late at work, an extra 2 hours just doing charting. So it's I'm going to do it while you're talking to me, but it takes away the personableness
Yeah.
of the healthcare.
It makes it feel very robotic. And how are you going to establish a really good relationship like that? Because they feel like they're not heard. And how can you be if you're looking at the side of my head because I'm facing my computer?
Yes.
So a lot of times I don't even turn the laptop on in the room, or I don't even bring it in with me. As you know, I will bring my tablet and my
no, you used to have the notepad.
Yes, that's what I meant. I meant a writing tablet, a notepad, just one of those spiral bound little ones that I could put in my pocket. And a trusty pen, and I'll jot down a few things just so that it triggers me to, remember to document something.
Put it in the notes,
but a lot of times I'm writing on scratch pieces of paper, and I'm just keeping it old school. Some things you have to keep old school, and that's one of them. So we're going to talk face to face. You're closed. I'm facing you. You're not even on the table. You're sitting in a chair just like I am, and we're going to talk, and we're going to establish that trust. And you're going to feel heard. Then when we have all of that done, patients feel a little bit better too. That's the other thing too. A lot of times I don't like to take vitals at the beginning of the visit because people are nervous, myself included. I'm a healthcare provider, but I get white coat syndrome.
Yes, that's so true. Especially if they're coming in with a problem, they don't know what you're going to find, what you're going to tell them, so they're anxious. So if you do the vitals at the end of the visit, they've already heard what you have to say. They're calm, they understand, they have a plan.
Yes. Or I'll ask my MA, get it after we have our face-to-face, like before they get ready to get changed, because they're already feeling better. It's like, it's not, whatever a patient is coming in for, it's not that scary.
Right.
It could be anything. It could be the discharge you're having. It could be the pelvic pain that you're having. It could be some irregular bleeding. It's going to be okay. Right. It's never that severe. It's going to be absolutely fine. And 9 times out of 10, it's really nothing that we can't fix. It's nothing too, out of the ordinary.
Yeah.
And so
I think I'm going to actually practice that way. Do the vitals after the visit. Because the problem is, how our EMR is set up. It's like, you got to put the vitals in so you can go to the next page. You know what I mean? So it's like, all right, let's get the...
we're just in that habit of, clicking. Next. And we've taken away that simple humanity of a healthcare visit. I don't like it. I really don't.
True. It's really...
And that's how I practice differently. I am intentionally slowing down. I make that very intentful when I slow down.
But then that means you're staying late.
It does, but that's okay.
But then your patients love you.
My patients love me. I've yet to have a patient complain that I spent an extra 10, 15 minutes with them, right? And then when I go into the next room, that patient that's been waiting for me because I went over, I tell that next patient, I just spent the time that was needed with the patient before you, and I'm going to give you that same dedication and that same amount of time until you're satisfied, and I know that I've done everything that you came here today for. And
your coworker, she will go into a room and she's like, "Ow!" And we're like, "How is she doing this?" Remember?
She was so fast.
Yes,
so fast. Yes. I could never do that. I was just like, she blew my mind. That's talent.
And that's not talent.
Yeah.
That's just...
She could do like 20 annuals in like an hour, and not leaving me in the dust.
And we were all, and I remember going into a room with her one time. I think I told you, and I was like, I was even confused. Like, I don't know when the visit began, and all I know is we walked out of the room, and I'm like, I can't even imagine what the patient felt like.
She gave great care, though.
She hit
all of the points, and some people want that. Some people just like, look, I hate the gynecologist. I'm here because I have to be for 1 year. Get me in and out in 5 minutes. I'm going to give you great Google reviews.
That's true. That's true.
So that's the provider you need. That's not me. We're going to take our time
and talk. I think it's different personalities, I guess, but I want a doctor that wants to talk to me. Like, I go to my dentist, and I know it's like, he writes little cheat notes on every patient's chart, but he would go and he'd be like, "Oh, so how was like the previous visit?" Maybe I'll tell him something like, "Oh, I'm going to whatever, New York." I'll come back 6 months later, and he'd be like, "How was the trip to New York?" And I know it's because he wrote it on my chart. But just because he says that, I'm like, oh, that's so sweet. You remembered I told you I was going to it.
Right, because he could have ignored it and just been like, hey, you look great. Everything's great. See you in 6 months. Right. Yeah. But he didn't. And he chose to be mindful of that. And I love that. It's really important. And that makes people advocate more for themselves when they have those experiences. And I tell patients, if you haven't had that experience yet, like let's say with your primary or your GI doctor, whatever, then you need to keep finding. Sounds like to me, you need a new provider.
Yes.
Right.
Because there are good providers out there.
And that's what advocating is about, is keep going until you find the one that meets your needs.
Works for you.
Right. Absolutely. It's important.
It's your healthcare. So you have to, take it in your hands and do what works for you. All right. So tell us any new emergent trends that, you're seeing in women's health, anything new coming up that maybe is interesting and we can look out for.
Well, we have new meds that are coming out. I mean, there's always new progress for that. But I love, even for which, we touched a little bit on earlier, which was endometriosis. So, 10, 15 years ago, we didn't have the treatments that exist now, like as far as medications. So we have like newer medications that we can use for that, different ways that we can tackle that. And we're finding, with even more and more, we have new meds that are coming out, new ways to deal with issues before, that were so different. Let's say for fibroids, for example, 30, 40 years ago, the treatment for fibroids was, guess what? Getting your uterus removed. It was a hysterectomy. That's what my mom had done. She had hysterectomy, I think probably age 40.
Yeah.
Right.
Very
we don't do
early.
that anymore.
No, people are still having babies at 40.
Yeah. We don't do that anymore.
Yeah.
That's not the go-to. In fact, that is the far end of the spectrum that we even consider. There's so many more steps in between now. And so those are the things that I'm really excited about. And I'm excited about some, not all, some of the things that I see on TikTok. You got to watch that TikTok. Some is good, some is bad. But I like the fact that TikTok is starting conversations. All right. And it's empowering people to start to speak up about what they are and are not going to tolerate in the office for a visit. Like, let's say, for example, there's been a push on IUDs. And I know that this trend was, started on TikTok about how painful they can be. Right. And so I know, and my teenage daughters would, bring this to my attention and say, Mom, is that really true? And I would say, absolutely, it's true. I don't make it a habit to lie to my patients. I don't tell them it's just going to be a little pinch.
No,
it is not a little pinch.
No.
It is a painful procedure. It's tolerable, yes, but you deserve to know what you're coming in for.
Yeah.
It's painful, but there's different steps that you can take to make it as least painful and as most comfortable as possible, from using meds the night before to taking a higher dose of ibuprofen an hour before you come in, for having providers that use heat packs on the lower abdomen, things like that. Using relaxation techniques in the office, talking to patients, tell them, hey, put your Spotify on, what's your favorite music, blare it up, getting the patients to relax. So using a lot of different techniques, right? But having the conversation, like, why are we still tolerating painful procedures in the office, right? You wouldn't have a root canal without anesthesia, right? Even if it's just local, right? A man wouldn't.
Exactly. And this is an even more sensitive area than your mouth or, like anywhere else in your body.
Exactly. And so if we wouldn't tolerate that, and that's a relatively fast procedure. I mean, I've had them before. I have an oral surgeon who can do it in like 15, 20 minutes, right? So just because it's a short procedure doesn't mean
the pain is
it's not painful,
there,
right? Because I've had a lot of male GYNs that I've encountered in my career so far, where we've had this conversation. It's like because it's a very fast procedure. It only takes minutes with the IUD, and so it doesn't matter how painful it is. It's quick. And I said, wow, that's really a bad attitude.
Because you're not the one feeling the pain.
That's right.
That's why you're saying
absolutely.
that.
And you know what? They do leave the office and they continue with that pain for the rest of the day. It can be very crampy for the first few days when you have an IUD. Not only that too, but that can be a very traumatizing experience, especially if it's a young patient, like someone who hasn't even had a baby before. It's a little bit different once you've had a baby, if you've had a vaginal birth, because the cervix has sort of been through that a little bit. It's been dilated a little bit, right?
It knows, it's familiar.
So, but when you have a young patient, maybe a 25-year-old coming in, had never had any babies before, never been pregnant, wants that IUD because they want that freedom where they don't have to take a pill every day, right? And you do that procedure, and maybe they find it extremely painful. It can be very traumatizing for them. Now we have a patient that doesn't even want to come back in for her annual pap smear, or for when she's due for her next pap, coming back in for that because of the trauma from that, right? Or how about when they go wrong?
Right.
For some reason you can't, the cervix doesn't dilate. You can't pass anything.
Then you have to put a little pressure and then.
Right. You're trying to sound. It gets more painful. And then you just stop the procedure because maybe the patient, says to stop. I can't tolerate it. I don't want it. Now what? Now you have that really bad experience. And
You're not going back.
And so I like that TikTok and those other social media platforms are at least forcing us to have conversations and making us think. And now, I have a lot of different stories I hear from patients or from people that they know that they're using things like nitrous oxide now in GYN offices for procedures like IUD insertion, colposcopies, leaps, things like that. So that's a great thing. So you can find a provider who is offering you maybe not just nitrous, maybe even other alternatives for you for pain relief. Then certainly that is,
I forgot to ask you this, but since we brought up birth control, what would be your advice in going about deciding which form you think will be best for you as, as a person?
Yeah. So what I do with a patient is I take a look at a lot of factors, their age, whether or not they've had children before, what their plan is, when we kind of try to forecast, you're looking to have a child in the next year, you're looking in the next 5 to 10 years. That changes the landscape a little bit, right? Maybe they want to do a pill because they want to try for pregnancy in 6 months or a year, rather than going through the IUD insertion. Now in 6 months, we're going to pull it out, things like that. So, I give patients all of the choices. There's pills, there's patches, there's rings, there's injectables, there's devices like the IUD, the Nexplanon, things like that. They have a right to hear every single option. Every single patient has the right to know every single option for them. And then we do shared decision-making process, based on all of those factors, their age, their underlying medical conditions, right? Maybe they have, could be someone young, but they still might be hypertensive. Maybe they're smokers, right? Which is a bad habit.
Yes.
So I am going to put a little bit of heat on for them to get them to stop smoking, but it's something we want to consider, because if we give someone who is an active smoker a product that has estrogen in it, like an oral contraceptive, it increases the risk for stroke. So we want to be mindful of that. We want to have those conversations, right? So those are things. We want to look at things like BMI. Someone that has an extremely high BMI, some methods may not be optimal for them, right? So we'll talk about all of the options and then let the patient decide which one they want to, start with. And I tell them too, it's not written in stone. You might want to try the pill for 6 months or a year and then decide, you know what, I don't really like this pill. I want to try something else. Maybe they want to go for the arm implant after that. Like, it's not
right.
It's not just
you can switch it up. If
absolutely.
One doesn't work, you can switch to something else.
Absolutely. Yeah, absolutely. The choice is always theirs. But one thing I will say about the birth control pill, because I don't think as a society we do a great job of educating. Birth control pill is not immediate. And I can't tell you how many times I have this conversation. Patient will come in, I want to talk about birth control. I don't want the pill. It's awful. And I'll say, well, tell me about that. What was awful for you? Or I took it for a week. It was the worst pill I ever took. I bled right through it. A week. Now, I will tell them, okay, I'm really sorry that you had that experience. I can understand how having all of that unscheduled bleeding was very inconvenient for you, for sure. But that was your body doing what it was supposed to be doing. It's trying to get adjusted to the pill. You are supposed to ignore that. That's called breakthrough bleeding. You have to try a pill, at least a minimum of 3 packs, before you even know if your body's going to even adjust to it or not.
And 3 packs. So that's 3 months, basically.
3 months, right. Now, most people will bleed through that first pack, or they'll have some amount of breakthrough bleeding, irregular bleeding, right? Ignore it. I tell them, don't even call me, tell me about it. That's how common it is, and that's how much I can tell you is going to happen to you. I don't need to hear about it. Keep going. Ignore it. Keep taking your pill, same time every day, go about your life. Second pack comes around. It's a little bit better, but they still have some. It's fine. Keep going. Keep taking the pill. Don't call me. Third pack comes around. It usually starts to stop by then, because now their body's getting adjusted. The ovaries are shutting down. They're going to sleep like we're telling them to. They feel pretty good. And if not, they get into that number 4 pack. They're still having unscheduled bleeding. Now it's time for us to have a conversation. Okay. Because not every particular formulation of pill is going to work on everyone's body. Everyone's chemistry is different, right? You and I can take the same pill. You will love it. I might hate it. Right. It doesn't mean there's something wrong with the pill. Right? Yeah. It just means that chemistry is different. Yeah. So that's why there are just so many different formulations of birth controls. Yeah. So you got to stick it out.
So you have to at least try, if you're starting a new birth control pill, this is the pill, not the other form. If you're trying the pill, you have to at least give it 3 months, 3 packs. And if you're still having issues with it, then you go back to your OBGYN and have a discussion. Yeah. All right. So what are some common misconception that people have about women's health? Maybe even females and males, like some things that we think is, something else, but it's not.
Yeah. So the discharge is the first thing that came to my mind. I know we talked about this a little bit earlier, but discharge, it's perfectly normal. And you're going to have discharge that differs throughout your whole cycle, depending where you're at in that cycle, right? We know around ovulation, it should look like egg white consistency. It's going to be thick and sticky, clear, right? That's when we know. Normal. And there's purpose to that, because the body's purpose is to capture the sperm and bring it in and get it to travel, right? It wants to take it in. It doesn't want to expel it, right? And so discharge changes throughout the month based on where you're at in your cycle. So having a discharge, even if it's every day, is 100% normal. I'll have patients say, well, sometimes, when it's dried on my undergarments, I can see it, it's yellow. That's normal. It's totally normal. It can look different, shades of white. It can look a little yellowish tinge.
The
and the oxygen
Yeah, the
oxidizes.
viscosity, I guess, is, yeah. Whether it's thick or thin, those are all okay.
Yeah, all normal. What's not normal is if it has a foul odor to it, if there's intense itching with it, if it's, you know, copious and looks so much different than your average everyday discharge, right? If you're having pain and burning, right, especially after intercourse, or maybe it's with after a new partner, where you're having pain and burning when you urinate, all of those things can be red flags for, okay, maybe this is not so normal. But if in the absence of all of those things and you're having some discharge, it is 100% normal. And the other thing is too, is having a little bit of a foul odor about 24 hours after intercourse. If you're not using protection and your partner has been inside, you can be having a little bit of a local reaction to semen. 100% normal. I tell patients give it 24 hours. Because sometimes it's an offset into the vaginal pH. That's very normal. It's very common. And the vaginal microbiome can reset itself. So give it about 24 hours. Most cases, it self-resolves and we don't hear anything else about it.
There's no need to, like, you know, put any spray or anything like that.
That's a good one.
Yeah, it all changes the microbiome, the pH level down there, and you don't want the vaginal canal cleans itself.
Absolutely.
Correct?
Yeah, we always called it the self-cleaning machine.
Exactly.
In clinical.
So, yeah. So you have to give it time to clean it. Unless something you notice a smell, it's not what you usually have, or the, like you're saying, the discharge is more, the color is different, then you seek help. But there's especially the over-the-counter sprays and douche and all those things.
Yeah, please don't use those.
Yeah.
Please don't use those. You do not need to put anything inside there. That is such an old wives' tale from decades ago when, you know, they were marketing those products. And that's probably what got the mindset started in all of these generations that think, oh, I smell down there. You know, the discharge I'm having is not normal. You're supposed to smell like a female. That's what you're supposed to smell like. You're human. Right. You're not supposed to smell like flowers and lavender and whatever else. That is not normal. Okay.
Oh, roses.
Yeah, roses. That is not normal. That is not normal. Okay. Please don't put anything in there. Not even soaps.
Yes.
I have some people that come in and they're all irritated because they've been sticking soap up there trying to clean. No, no, no. Just plain warm water to wash the inside. That's all you need. The outside, that's a different story. You tell folks, certainly in the outside areas, you can use some soap or whatnot, but please, inside, you do not want to get it up and in its inside. That's when problems can arise.
Yes.
Absolutely. Right. And another thing that I see in clinic too is chronic yeast. Chronic yeast. And a lot of times it's related to the products that they're using.
Exactly.
They've got these new moisturizers and creams and perfumes and they're putting it everywhere, not realizing.
They even have whole body deodorant. So you use the same thing in your armpit as you use down there. No.
Yeah, don't put it up and inside.
Two different body parts that shouldn't be using the same products. So don't do that. You're just setting yourself up for things like yeast infection. So don't do that.
Yeah, absolutely. And if it concerns you, you should be able to call your provider and have a conversation.
Exactly.
Yeah.
All right. Any advice for women of all different ages, young, old, teenagers, people coming up?
So I would like to dispel a rumor that pelvic exams are painful.
Okay.
They are not. They shouldn't be. Yeah, they should not be. And I'll have a lot of patients who are very shy when they come in. You know, maybe it's their first, you know, maybe they're 21 now and now they need the pelvic exam, you know, the pap smear, or maybe they're even older and they've never had that exam before. The first thing I tell them is whatever you've been listening to on TikTok, right, or any other social media where they're telling you that this is going to be painful and it hurts, especially the pap smear, I tell them 100% false. And I am 100% going to guarantee you that my exam is not going to be painful. In fact, I'll tell them you can punch me if you would like when the exam is over. If I've hurt you or if I've made this exam painful, you can give me some pain too. And, you know, they'll laugh at it like, oh, I'm not going to hit you. And I'm like, I know you're not, because I'm so good at what I do that this exam is not going to be painful. Now, uncomfortable?
Yes.
Maybe.
Pressure.
Different. It's going to be different, right? Because we don't walk around with speculums inserted in our vagina, right?
Yes.
So it's going to feel odd. Strange, but it's not painful. It should not be painful.
Yes.
I do the most gentle insertion. Well, you've seen it.
Yes.
I've never had a problem.
We have seen a lot of hoo-has between the two of us.
We have. And did I ever have a patient say,
no,
this is absolutely painful? This is
no.
no. And I've even worked with patients that have had sexual trauma before, you know, rape victims, you know, people that have had just generalized trauma, no problem. They're one of my favorite people to have because I get them through that anxiety and we get through that process. It's the most rewarding part of our day, you know, when we do what we do.
When you actually see a difference.
Yeah, but I'm going to tell you, you know, and the thing is too, you want a provider that's going to give you that reassurance. It's going to take their time with you. They're going to walk you through everything. And I certainly do that. I show patients the speculum, you know, or I give them the option. Do you want to see it? This is what we're going to do in the exam. This is what a pap smear is. This is the equipment that I use. You know, I'm not going all the way up into your throat. You know, going into your vaginal canal, it's only about 3 inches long in the unaroused state. I'm not going to get a tonsillectomy here. Right? I'm only looking for your cervix, right? It might feel a little bit strange, a little bit uncomfortable, and maybe a little cold if we're using a metal speculum. But a lot of times we have warmers on them. So we try to make it as comfortable as possible, but it's not going to be painful. So if that's what's holding you up from going, please understand it's not going to be painful. And if it is,
find a different provider.
Get a different provider. Yeah, absolutely.
Yeah. Well, we've learned a lot. I've learned a lot. So thank you so much for coming and talking to us. I so much appreciate it. You have no idea. I can't believe you came.
I'm so excited. No, this is great to be here. I love doing this. I hope that we were able to give some really good, important information, and I hope we were helpful.
Yes. And I definitely think we were.
Yeah.
Yeah.
Good.
So Gina is, like I said, a women's health nurse practitioner in the East Coast, in New Jersey, New York, Pennsylvania area. So if you're in their area and you're looking for a women's health nurse practitioner, you're taking patients, right?
We can do telehealth too.
Yeah. So, she can do telehealth. So nationwide.
Yeah. That's another thing too. You don't always need to have an in-person visit.
Okay. I'm going to put your, can I put your number or your email?
We can put our contact information in there.
Okay. So reach out to her. I'm telling you, she's an amazing. I have seen you counsel people. Remember we had a couple that came in for fertility counsel. And it was like you probably don't remember. It was an older man with a younger girl. And so she does it all. Anything female related. If you're trying to get pregnant, if you are pregnant, she's great. So I'm going to link her information down below and you can contact her with any women's health issues. Thank you guys for watching and I'll talk to you soon. Bye.
Bye-bye. Thank you.